Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. Measles was declared eliminated in the United States 25 years ago, but cases are sharply rising. Dr. William Moss, a Johns Hopkins immunization expert, joined Stephanie Desmond to discuss the process of declaring whether or not the U.S. will lose its immunization status, what that declaration could mean, and how to boost demand for vaccines in a world with increasing rates of mis and disinformation. Let's listen.
Bill Moss, thanks so much for coming back to the program.
Great. Thanks for having me, Stephanie.
There's been a lot of talk about measles lately. It was declared eliminated in the United States in the year 2000, but we're seeing a lot of new cases right now. Paint a picture. What's happening?
Yes. As you said, the United States had declared that measles was eliminated in the year 2000. That doesn't mean that there were no cases in the United States. There have been cases of measles in the United States every year since then. But what that means is that there was not continuous transmission of measles virus for 12 months or more. That's how we define elimination status. So what's happened is that last year in 2025, we had more cases reported in the United States since we've had since 1991, when there was a big outbreak across the United States, from actually extending from 1989 to 1991. Last year, 2025, the CDC reported 2,286 cases. So the most since we've eliminated measles, the most since 1991. This year, we've seen an even sharper increase in measles cases, and the CDC just updated their numbers and are reporting 1,671 cases just in 2026. So if this trend continues, we will easily surpass the 2025 number of cases. Some other facts about these outbreaks extending from 2025 to 2026. We're seeing measles cases in a wide age distribution. Over that time period, roughly about a quarter of the measles cases have been in children younger than 5, so young children. About half are in school-age children from 5 years to 19 years of age. And we've even had, maybe a quarter to a third of cases in adults older than the age of 20. So what this indicates is that, one, we're seeing a lot of outbreaks within schools, and two, that this is a problem that's long been in the making. This represents under-vaccination or unvaccination in certain communities, extending over many years. This is not just a recent phenomenon. If that were the case, we would be seeing the measles cases would largely be in young children, but we're seeing a very wide age distribution of cases.
So why are we seeing so much? Why aren't people getting vaccinated for the measles like they used to?
It's a complex question, and there are multiple reasons why we have low vaccine coverage, both here and around the world. One way to think about it is it falls into kind of two categories: access to measles vaccines or vaccines in general, and demand. There are some communities in the United States where access can be difficult, remote rural areas, particularly for children who are uninsured or underinsured, where it's particularly challenging perhaps to find providers of vaccines, particularly under the Vaccines for Children's program. But the bigger problem is in demand here in the United States. And again, there are many factors that drive the demand for vaccines. But what we've seen is a slow but steady decrease in the proportion of kindergarten students in the United States who are receiving all vaccines, but particularly the measles, mumps, and rubella vaccines. That number has dipped from around 95% to around just over 92%. It's a small percentage decrease. Accompanying that, we've seen a rise in what we call non-medical exemptions for children attending school, where there are school vaccine requirements up to, 3.6% or so. So we've seen this kind of steady decline in vaccination rates. But again, as I indicated earlier, this has been a problem long in the making. And it's in particular communities where they may say for religious or philosophical reasons, they decline to have their children vaccinated. And there's also been a lot of misinformation and disinformation spread around vaccines, particularly the measles vaccine, that have contributed to this vaccine hesitancy or vaccine skepticism. And the outbreaks are occurring, the bigger outbreaks here in the United States are occurring in those communities with particularly low measles vaccination coverage in specific age groups.
You talked about measles elimination status. The review of U.S. measles elimination status was delayed until November, which is after the election. They gave technical reasons for it. From your perspective, does this delay improve the science or raise concerns about the timing?
Yes, I know there have been some concerns about that delay. According to the Pan American Health Organization, is the organization where the measles elimination kind of verification committee sits, there are two reasons why there has been the delay. One is that the U.S. government requested more time to do some analyses on measles virus genotyping. And I'll just say a few words about that. In order to determine whether or not we've had continuous measles virus transmission in the United States for 12 months or more, remember that's the criteria for elimination, one would have to show whether or not the outbreaks in the United States reflect this continuous transmission or actually represent multiple independent and different importations of measles virus in the United States. That's another way we could have had measles cases over this period without having had continuous transmission within the United States if we had these multiple importations. So how do we determine that? There are kind of two types of evidence that are used. One is to investigate whether cases are what we call epidemiologically linked. So for example, if it was very clear that someone with measles went from West Texas to Utah or Arizona and started that outbreak there, that would be an epidemiological link. But there are a lot of holes or gaps in the epidemiological data. It's just very hard to capture all the cases and all the potential contacts that might contribute to that. So a second kind of body of evidence is actually looking at the measles virus itself and its genome, its sequence of nucleic acids, because those are going to change over time. Now, it's very interesting. Historically, the global community has identified 24 different measles virus genotypes. That's kind of our basic classification system for measles virus for many years. And this is based on sequencing a very small proportion. It's actually 450 base pairs of the nucleocapsid gene of the virus. And that allowed that classification system into 24 genotypes. But over the years, in response to global immunization efforts, drastically reduced the number of measles virus genotypes circulating in the world, such that right now there are only two. One is called B3, the other is called B8. And the fact that there are only two measles virus genotypes doesn't really allow us kind of the fine resolution we need in order to determine whether or not there's been continuous measles virus here in the United States over the 2025 and 2026. And just so you know, the genotype there's a particular genotype called D89171 that has been identified in West Texas and Utah and South Carolina. So we know we have that one genotype, circulating in the United States. There have been some B3 genotypes imported, but it's largely been this D8 genotype. But again, that level of genotyping doesn't allow us the resolution we need to adjudicate on the elimination status. So what the United States has been doing, and this is really kind of the first time a country has done this as part of a measles elimination verification process, is doing what we call whole genome sequencing. So instead of just sequencing these 450 base pairs of the genome, now sequencing the entire measles virus genome, which is about 16,000 base pairs. This allows us much finer resolution. The state of Utah Department of Health has been really good about genotyping viruses and making those measles viruses, making those genome sequences public, both from Utah itself and from other states that have contributed specimens there. And now we're learning about an effort to sequence a much larger number of measles virus genomes. The Broad Institute is involved in this. The reporting has been that about 1,000 measles virus genomes have been sequenced, this whole genome sequencing, and we expect more. And so it's kind of doing that laboratory work, doing that analytical work that in part has delayed this decision on measles elimination in the United States. Part of this is it's unfortunate, but is due to the fact that staffing and resources at the CDC, particularly the measles lab, have been created challenges. Staffing shortages and funding shortages have created even further challenges. Now the CDC is relying on other partners like the Broad Institute to do some of this work, or the Utah Department of Health. Part of the reason for the delay in making that adjudication on measles elimination status is for this reason, to allow time for these analyses to be done. And also what the Pan American Health Organization said is that they're also going to make decisions about measles elimination status in Mexico and Bolivia, and they're trying to combine some of these processes for verification or loss of measles elimination status.
Most of us have not come across measles cases in our lifetime, and we've sort of forgotten sort of how bad it can be. Tell me a little bit about why we don't want measles back.
You know, Stephanie, when I talk about this to students, I often say, and many people say something similar to this, is that, immunization programs undermine themselves through their success, because a successful immunization program will prevent disease. People won't see it, and they'll forget about how serious these diseases can be. Now, I will say, in most healthy children who have measles will have an acute infection and recover. But there are complications of measles, and these are more severe. For example, children with measles are at greater risk for getting ear infections. They're at greater risk of getting pneumonia, lung infections due to secondary bacterial infections. They can get diarrhea. Importantly, there are rarer neurologic complications of measles. So, for example, an encephalitis can happen. There's a very severe, it has a fancy name called subacute sclerosing panencephalitis, which is a progressive neurologic disease that occurs maybe in about 1 in 5,000, 1 in 10,000 cases, particularly in children who get measles younger than 2 years of age. That's a progressive fatal disease. And measles can cause death. As many people know, we had 3 deaths in 2025 attributable to measles. 11% of cases were hospitalized in 2025. So measles can be a severe disease. And unfortunately, as we see more measles cases here in the United States, we're going to see more of these complications, more hospitalizations, and I hope not, but potentially more deaths.
If measles is back, and it seems to be, what does it say about the rest of our immunization system?
Yes, that's a great question. And we in the immunization or vaccine world often talk about measles being the canary in the coal mine, the signal of a weak immunization system. And that's because measles virus is so highly contagious. It can find the gaps. It can find those who are susceptible to measles, and cause large outbreaks. So the fact that we're now have 671 cases of measles just this year, just in the past 3 to 4 months, shows that there are a lot of gaps in our protective immunity, and doesn't bode well, for other vaccine-preventable diseases here in the United States. Another good example, very infectious pathogen causes pertussis or whooping cough. It's a bacteria, Bordetella pertussis. We've had tens of thousands of cases in the past couple years due to pertussis, another vaccine-preventable disease. And if we continue to see drops in vaccination coverage, we're going to see more and more vaccine-preventable diseases. And we just should not be in that place right now in the United States.
And the solution is?
The solution is increasing vaccine coverage by ensuring access. Let's go back to what we talked about before, access and demand. So we want to ensure that all children in the United States, all people in the United States have access to vaccines. But more importantly, I think the bigger challenge here in the United States is increasing the demand. And that involves kind of countering misinformation or disinformation as best we can. That's hard. And that can be done through identifying the right messages delivered by the right messengers. And this really has to be done at the very local level, understanding the community's concerns and trying to address those concerns, and really having, vaccine champions, vaccine advocates, the right messengers. That can be sports figures, that can be religious leaders, celebrities talking about vaccines. And we also need, and this is where we've been deficient, we also need a strong federal response. And we've not seen that in the past year and a half with the measles outbreaks that started in January 2025. We've gotten mixed messaging around vaccines. We've heard from the Secretary of Health and Human Services unfounded treatments, whether it's antibiotics or steroids or vitamins for measles. And we really need much stronger messaging from the federal government on the importance of vaccination.
Bill Moss, thanks so much for joining me.
Thank you very much, Stephanie, for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.